So, ladies and gentlemen, welcome to COV-advent talk organized by the ÖHKL. So it's a student body of the Karl University. My name is Tim, and I would like to extend a warm welcome to everyone who's watching today at this talk. Over the past 2 weeks, we've had the chance of having two doctors giving you some insight into their perspectives into the whole topic, into the pandemic. And over last February, I had the chance of going to Myanmar and had the chance of doing a clerkship with Dr. Olivier Cattin, who is a French doctor specialized in tropical medicine. And that's how I got to know our next guest speaker for today. Dr. Olivier will talk about the SARS-CoV-1 and SARS-CoV-2 pandemic, and will make a small comparison between those two pandemics, and will look at more the practical side in terms of the view of a physician. Before we start, I would just like to inform you that if you want to, or if you have any questions, we have the option of having a chat function right to the side of your screen. Please do not hesitate to ask any questions. I will collect all of those questions and then ask them and forward them to Dr. Olivier at the end of his talk. So now I hope you find a lot of interest in this next topic, and I hope that you have a lot of interest into both of those SARS-CoV pandemics. And so now I would like to extend my warm welcome to Myanmar. I know it's quite late in Myanmar right now, but thank you anyway for joining us today. And I would like to extend the word now, or hand over the word to Dr. Olivier.
Thank you, Tim, and thank you to Australia. And it's a great pleasure to talk tonight. And it was a great pleasure to have you in late February last year, just before the coronavirus hit Myanmar. So just quickly, I will introduce myself. I'm a French physician, been in Asia for 20 years, working in 5 countries, Vietnam, and the last were Vietnam and Myanmar. I had the chance to have my life gave me the experience to have the first index patient of SARS in Hanoi in 2003, and to receive the first index patient of coronavirus in Myanmar just after Tim left. So just when Tim left, we had a full fun in the clinic, and we go back. So I would like to make 2 comparisons, because we've been talking a lot about the new coronavirus and lots of things. Thousands of publications have been published, but the fundamental of the coronavirus are known from 20 years, and from the SARS in Hanoi in 2003. You can go to the next slide. We already draw the fundamental of the outbreak and infection control. So 2003, I was working at a French hospital in Hanoi. You can go to the next slide. I was the medical director at this time, and we receive. We receive a Chinese patient from Hong Kong, and with a high flu and a funny chest X-ray. And we were aware at the French hospital in Hanoi that one outbreak was going in China, because the Airbus team from Vietnam was supposed to work in China, and the trip had been cancelled, as something weird was going in Guangzhou. So when the guy came, the first patient came, the index case from SARS outside China, Mr. GC, he came to the clinic with a high fever, chest pain, bronchitis, and this, what well described now, this gross close opacities. But the outbreak was ongoing in China for a while, almost for 2-3 months, we don't know yet. And the super spreading event has happened at the Metropole Hotel in Hong Kong, which has been very well described in the literature. And you have a slide from the French Microbiology Society showing that one guy super spreader can contaminated one ward. So next slide. Index case came to Vietnam, and with strange symptoms, this gross glass opacity is a chest X-ray, lymphopenia, absolutely no idea what it is. So myself aware something was weird in China, we call immediately WHO to say, please give us information. call a cardiologist, call a chest physician, call a person institute, do the workout that you are learning now on the atypical chest infection, mycoplasma, run PCR for flu. And the guy managed to be flu positive B. So, and let's start the story. Next slide. And 4 days after the admission, well, the patient went for IRDS, like is well described now for COVID. Typical, just from one day to the day was complete respiratory failure. It was PCR flu B, so say let's start Tamiflu, let's start the standard procedure for severe influenza, call the intensivist from Hanoi to say how we can ventilate, because as we know now from COVID, to ventilate people in IDS is pretty a challenge, and we finished with a tracheotomy with the patients, try to play with the ventilators, which is now well codified, thanks for the work over the last year from clinicians all over the world, and starting by China and Italy. And what a surprise, 5 days after admission, we have two nurses, the two senior nurses were sick. So I give you some data on the right of little symptoms, which are extremely different from the clinical picture of COVID today, because people were super symptomatic. This is high fever, 40 degrees, cannot move, headache, joint pain, and really they were going to get a feeling they're going to die. Super symptomatic patients. Next slide. And so 1 week after admission, we have 40 nurses were sick. I say, what's going on? Same profile, lymphopenia, ground glass opacities. So Carlo Bani finally came after he came just after 5 days, and I say, well, please, let's go, let's start to do a real epidemiology survey. Let's cross-check the PCR with the Pasteur Institute. Let's calculate the secondary attack tests. What is our attack tech? We've seen talking a lot about R0 on the COVID. Attack tech and R0 are not too much far away, but attack tech is pretty practical in a closed community in hospital. You can easily calculate your numbers. At one case, we contaminate this case, and this is a pretty easy calculation to do. And we say it's a quick and dirty epidemiology, which is the best epidemiology. Field epidemiology is the best, quick and dirty. Don't go to complication. All experts have been wrong on the new coronavirus. This will remain quick and dirty. What is it? The numbers matching flu or not matching flu? At this time, we start to implement PPEs. We do not do flu PPEs. We say, okay, I see we put A95 surgical gowns, goggles, like we do for atypical or new flu strain, like we say might be a new strain, we don't know, B strain. And at the same time, we have to move back our patient at the request of the family to Hong Kong. Next slide. Let's say the genius of a good epidemiologist lies. Carlo Urbani is a fantastic epidemiologist. He's a clinician and an epidemiologist. He has clinical background and he can calculate numbers. Quickly, you realize that the attack rate of this new virus was 2 times, 3 times what we will expect with influenza. At once, he say, okay, we're not dealing with the same disease. The clinical profile, the ground glass opacities have not been described in influenza. The attack rate at 2 to 3 times more than influenza. There's something wrong. Let's cross-check all the PCR with a lab in Japan. Let's start local alert in Hanoi. Let's activate the worldwide, the regional network from WHO. Let's see what's going on. So at the same time, we start to isolate completely the ward, and we went to extreme that nobody did. We just locked the ward. We nailed the doors. We put security guards. We locked the X-ray machine in the ward. And we did what was life-saving for us with no patient movement. X-ray machine is fixed. Everything's coming to the patient. We don't move the patient to other ward. We just shut down the day after the hospital. And next slide. And the outbreak stopped within 10 days. 24 people went sick. roughly. Dr. Kerbali passed away. He was contaminated initially when he started interviewing the patient with just surgical gown. We just have a fabulous study showing when you implement N95, the different level of PPEs you're implementing, you can reduce the transmission. Once we pull N95, surgical gown, the pair of gloves, gowns, and shoe covers, goggles, we have no more transmission. And the hospital R0 were calculated posterior about 3. So Dr. Palespesoui just did initiate the global alert. Just start, we did not know about coronavirus. It came later. It came in April 2003 after Dr. Kerbali passed away. By the end of 2003, the outbreak was over. We had about 8,000 cases, 29 countries, and less than 1,000 people died, and the mortality rate was quite high with 10%, with the same risk factors. Age was a cardiovascular disease, diabetes, and like we have outliers, where the youngest doctor who died in Hanoi was 38 years old. He was just tired. He was a gynecologist doing shift. From this outbreak, it was a success. From WHO, it was a success worldwide. It has a major impact in tourism, travel, but everything was new about coronavirus. We knew the R0, we knew the route of transmission, we knew the airborne role of transmission, we knew the format, etc. Next step, well, and we go back to Myanmar, where I've been working since 2006. Next slide. I will start a slide with the first speech of the lady. And it's important. It came a little later at the beginning of the outbreak worldwide. Quickly. So next slide. This is the timelines of Myanmar. Myanmar, when the coronavirus starts circulated in China, in Wuhan, and we don't go back to the deep analysis on what happened in China before China, etc., or any critical analysis of Wuhan. Burma, since the beginning of January, was aware of the transmission of coronavirus in China. I knew if the virus would come to Burma, it would be a disaster, because Myanmar are one of the poorest healthcare systems after North Korea in Asia, and we will not be prepared. So Myanmar did start prepare themselves extremely well, start committees, monitoring, etc., until we get the first index patient, and it came with French tourists. And the French tourists came to see French doctors, with 2 French doctors in Yangon. So they seen half the French tourists came to see my colleagues in one international clinic, and we have seen half of the tourists in our clinic. And well, bingo. So start again. 2 other repatriates were coming from, will be the next slide. So we start again, start isolations, start contact tracings, and lock down the hospital, exactly like we did in Hanoi, even as tough as we did in Vietnam, to try to control the outbreak in Vietnam. And it was a success story. We managed to have only 275 cases, roughly, 250 to 75 cases in Myanmar at the first wave, if we call a first wave. So it was quite a miracle. WHO and MOHS did some simulation. We're going to disasters. In fact, nothing has happened. The very strong public health system in Burma, the extremely good preparedness of the government, isolation, contact tracing, blockage of the airports, managed to control the outbreak. But we forgot something, which is the next slide. By mid-August, Burma is a country, as you know, with many boundaries: Thailand, Laos, China, India, and Bangladesh. Most of the boundaries of Myanmar are porous, especially with Bangladesh, where you have some ethnic conflict, and China, and less with Laos and Thailand. So by mid-August, the COVID cases have been reimported, most likely from India and Bangladesh, from the Rakhine region, which is a conflict-torn area where diagnostic testing were pretty inexisting or limited. So what happened? The outbreak started, and 2-3 weeks after, we discover that the second wave was starting in Myanmar from the Rakhine, southwest from Myanmar. And most people escaped Rakhine. They took the car before we can catch anybody, and they went everywhere in Myanmar, especially from Rakhine. You have 3 roads. You can go to Upper Myanmar, Mandalay, Central Myanmar, Pi, and Bagan, and South Myanmar, you can go to Yangon. The time for the Ministry of Health to realize that the second wave was in Myanmar, the infection was everywhere. Is the next slide. So you see the EP curve in Myanmar, EP curve, so the first wave, which is mostly imported cases, and the second wave, which is mostly local transmission. And we're still today struggling with this local transmission, which is a little better control in Yangon today, but not control at the national level. And now we're talking since today with MOHS and WHO meeting about the third wave. The third wave will be just a continuum of a second wave, is a polite wave to say that things are not under the way. So next slide, we can see just roughly the main issue was an asymptomatic patient. It took a while to realize worldwide that SARS coronavirus was super symptomatic. SARS-CoV-2, 80% I get mild symptoms, and you have a huge proportion from Burma, it's almost 60% people with no symptoms. And most of the symptoms of Myanmar patients are anosmia. So we have to change strategy in Myanmar completely and to look for. So absolutely, can go to the next slide. So to go to containment measures. So classic measures are well described as similar to all the countries in the world. You try case detection, isolation, contact tracing, treating. But in Myanmar, we need to quarantine a lot of people. So I've been quarantining people with symptoms. We call PUI, people under investigation, in hotel, medical quarantine and hospital, but also the contact. 40,000-50,000 people have to be quarantined in stadium, in monasteries, in school, and it's what's going on today, and try to contain the outbreak with the local capacities. In the same time, with the next slide, so Myanmar testing capacity was 0 in March, 0 PCR. So from April, we get a donation from Roche, and we get a Roche machine. We're able to run about 2,000 tests per day, and now we are around about 15 to 20,000 tests per day. We combine with rapid tests. Still, Myanmar in the region is the lowest country we can test. So you see Myanmar on the slide compared to Sri Lanka. Well, we are the worst. And it's not because of the bad will, because the Myanmar infrastructure are very weak. And to install a high-volume PCR machine is $500,000. It's lots of trainings. We don't have money. We don't have staff. So Burmese people have been trying to do the best. So when we start to get in late September, early October, rapid tests, especially from diagnostic from Korea, and a new generation from the US, Abbott and Roche, has helped us a lot to detect the case. The test today, they are running about we have 1,500 cases positive per day. They run 15,000 tests per day with rapid test, and that's where we are. Next slide, and you will see that all the challenge of Burma is like many countries. We try to do modelization, some prediction, everything went wrong. We know that the maximum capacities for treating is 14,000 patients a day. So the medication measure on Burma is to keep the numbers of active cases lower than this limit and to have more recovery cases. All the strategy is to mitigate. And since today, and will be effective by next week, we start to incorporate private sector. For some technical reason, was not authorized to test either by PCR or by rapid test. So today we are catching up on these tests, and from WHO presentation today, we try to reach the 250 tests per 100,000 people, which is not the case, and to bring back the positive slide rates, which is 7 to 8% to 5%. Still a struggle. I hope we will manage to succeed. I think everybody is on board, and it's still a challenge for Burma. Next slide. So my comments to see it's a purely clinical comment. So a lot have been said on coronavirus, a lot have been said in the outbreak. But people just forget the coronavirus are known for 20 years. We know how they transmitted. They know the reservoir for most of the coronavirus. We don't know the intermediate host for this one. We might never know. So many fundamental were known. We see lots of debate on R0. The R0 from COVID-2 is the same as COVID-1, between 2 and 3. But the mortality rate is not the same because the infectiousness is not the same. So the role of airborne transmission format is the same as before. So we lost a lot of time in this second wave debating with experts, which are with sterile debates. I've seen lots of people going back forwards. It's the same, the coronavirus behaves the same as a group. But this COVID-2 clinically is different from the others. So what is different is asymptomatic carriers, which is a huge problem for infection control. You need to do massive testing, massive contact tracings. So a country with poor settings like Myanmar is difficult or stretched. Vietnam, in contrary, with the second wave, they've been testing massively, up to 1 million people. They have a second wave in central Vietnam. They managed to lock the cities and test 1 million people, which was not possible in Myanmar because of Myanmar is still 20 years after Vietnam in terms of medical progress. So also the porous boundaries, Myanmar have little control because of conflict. People forget Myanmar is a country at war. It's not only the Rohingya you might have heard, is war on Rakhine. Today is the Rakhine army. Is at war in Kachin, is at war in Shan State in different territories. So it's very difficult to control the boundaries. And so that's why the virus has been so easily reintroduced in conflict areas, which is malaria or COVID is difficult to control. So you see in Africa with Ebola, the challenge is in a conflict-torn country to control an outbreak is extremely difficult. So the next slide will be my just conclusion. I will have conclusion. So I have a chance to work on infectious disease for many years, from HIV outbreak in France since '85 to different in tropical medicine since in 20 years in Asia. But just something we just have learned, dynamic of infectious disease is still something we don't know. We never since HIV, we never predict Ebola, we never predict multi-drug resistant TB, which is killing today more people in the world that coronavirus. We didn't see the first outbreak, second outbreak, and all experts, if you see some cognitive science in the US, 7 experts on 8 were wrong in the US and everywhere. From a little flu become a mass serial killer. So we don't know. We need to be humble as physicians. We know the virus, we don't know how they will express in a population with a new phenotype or genotype. SARS was yet to control as hypersymptomatic, and also it was a fabulous international collaboration at SARS, and the COVID in the beginning was essentially a big international mess up. Nobody wants to work at the EU level. Nobody wants to collaborate still today. It's still difficult to work with some countries like China to get the real facts on the beginning of the outbreak. So from the first beginning, we have been suffering a lot when Italian people were in drama. Well, we're not very brave. French were not very been superb with them. So even if it's selfish in this outbreak and not collaborating with each other. So the vaccines are coming, a new journey is coming on the infection, and there's a tremendous progress in vaccine. I think medicine we have learned a lot. And you are coming from a generation of doctors who are working on this new technology. And from this COVID vaccine, you will see new things coming, and lots of hope, and very interesting way of practicing your work in the next few years. From these outbreaks, discussing with a fundamentalist virologist, it will take us 3 years, almost, if it's not 10 years. Just to go back on what has happened this year, on the fake publication, the wrong publication, to try to understand what we have done good, what we have done bad, and from what we have done from this outbreak to better prepare for the next outbreak and keep the politics outside from medicine, because politics have been something too much involved from too many countries. So from this current outbreak, it's not over. The vaccine will just bring us a solution. And for us, Obama, a lot of hope, more than probably in Austria, where infections control and medical care is better. But at the end, 3 years of analysis, data analysis, and analysis on public health success, like it happened at the first wave in Myanmar, in Vietnam, in Taiwan, and failure, like it happened in Singapore, where they forget the dormitories, and like in Myanmar, we forgot the poor torn conflict zones where the virus been reintroduced. So lots of to be learned of this outbreak, and any infectious disease is dynamic. When I was in 1985, was a medical student like Tim and yourself. It was the beginning of HIV infection in France, and I remember seeing the first patient HIV and suffered dying from AIDS, and we did not know what it was, and it was quite a surprise. So infectious disease and medicine is an ongoing process. Curiosity, humility, team working is important. The success in Hanoi with Carlo Ribani, WHO, the Arnold French Hospital, Airbus, everybody's been to be able to work together, public, private, because I was working in a private hospital, collaborate with the public. So from Hanoi, from the SARS experience, also seem to be drawn in the SARS experience, so in the coronavirus experience today, to the next outbreak, and still in this ongoing outbreak, how to work together, how to be humble, and to be curious. Curious what one medication can come from one drug, it might work. So far, you have seen not too many things are working. Outside, cortisone and anticoagulant, remdesivir is gone. Big hope and a vaccine. It's over to you, Tim, and happy to answer to questions and to share more experience if you, as per the audience. Thank you.
Thank you very much, Dr. Olivier. So there have been a couple of questions that have come in, and I would like to start off with the first question about the transmission of the virus. It is said that the virus transmits less when you if in warmer climates. And so that's my question to you. In Myanmar, the climate is a bit warmer than here in Austria, especially right now. Have you noticed any correlation between warmer climate and less transmission of the virus?
It's a very good question, and you know, if you know Wuhan, central China, and the climate of North Vietnam and the climate of North Italy, wet, cold. So humidity and cold weather, which is very in favor of transmission of flu-type virus and coronavirus. In Africa, in Vietnam, and one of the reasons that we probably had the first wave was shortened in Myanmar, strong public health action, but also in Myanmar by April, the weather is 45, the sun is full UV. So you cannot, it's extremely hot. So it's just not, the loss of simulation have been done in Japan showing the opposite, but you see from just basic raw, again, the raw observation, just the basic observations, the field epidemiology, the quick and dirty sometimes is better than the complex modelization of things which are, we have too much bias. Warm and dry countries are not in favor of transmission of COVID. Cold and all respiratory viruses, flu, influenza viruses, Haemophilus, other for the kids, the RSV, cold and humidity, typically 5 to 15 degrees. We know from World War I experience that more people have been dying between 5 and 50 degrees and less by the cold weather or the extreme heat. It's just something need to be, again, in 3 years' time, reanalyzed. So far, very hot country, dry countries with lots of sun, most likely less transmission. And we know that UV light now are used for treatment, used for sterilization of medical premises.
And comparing this to SARS-CoV-1, is there a correlation between those two?
Well, it's the same virus. It's still a coronavirus. It's still the same family. So transmission by droplets, formite, and could be by super spreader with airborne. And what was interesting in Hanoi and was not been published because we lost the sample. Carlo Urbani asked us to recollect all the sample from the hospital, and the shipment between the hospital and WHO has been lost. 1/3 of the patients in Hanoi were co-infected with influenza B. So I've been discussing with some WHO experts, but we cannot prove it, so it's just a good guess. Super spreaders are co-infected with flu, and you could be, we've seen with novel coronavirus, it could be a dual infection, coronavirus and influenza. So the super spreading event do happen. What is the frequency? Well, SARS was a small sample, now a huge sample, which is COVID. To go back to do case control studies and retrotopic analysis would take a long time. Super spreading event, airborne transmission, yes, with coronavirus. That's why the first thing we did in Hanoi is to open the windows and put reverse fan. The first thing we did in Hanoi is to open the windows and change facilities with filtration, etc. This is the key things that we did in Hanoi with Carlo Urbani. Airborne possibility. So lots of debate about experts, lots of simulations, some are brilliant. Let's see about the case control studies. It takes lots of time to digest the gigantic volume of data we have now. Now, compared to SARS, we have too much information. SARS, we have little information, they were robust. Now we have too much information and lots of flaws. Different methodologies you've seen research and mortality rates in Europe between Germany, France, Italy. I don't know about your country. They're completely discrepant. You don't compare the numerator and denominator. You don't compare the same. You don't have the same methodology. So same virus, probably exactly the same way of transmission, probably same survival time on outside on formite, depending on the temperature, the surface, copper, plastic, etc. So the way to protect yourself, we define it in Hanoi. It works after 10 days, no transmission. It has worked everywhere in the world. The closed space is the most things, the closed space, and inadequate PPE and inadequate sequence of PPE is what we have identified in Hanoi to be the most important. So you can have fantastic PPE if you don't follow the sequence. You don't have a SAS because we put some different zone, and you forget about the airborne procedure like ventilation, or people intubated, ventilated, bronchoscopy. You just miss everything. Over to you.
Very, very interesting. Now, coming back to SARS-CoV-1, what measures were put into place once the pandemic started in Vietnam? Like, did you have a lockdown as you had, for example, now in Myanmar, or we are experiencing right now in Europe, or what were some of the measures that were put into place?
Well, we did exactly like we did Wuhan. So Wuhan did what they did in Hanoi. So when we first step was put basic PPEs. Second day we put N95 everywhere. And one thing with Dr. Carlo told us that things were not okay. We decided to lock the ward in the hospital, and we locked the hospital in Hanoi. So what we did, in the hospital there were 3 zones. The red ICU infectious, you have the orange zone, we have a partial PPE where people can circulate the staff caring after the patient. You have the green zone of the hospital where people were not in contact with patients, etc. But the hospital was locked, physically locked from Hanoi. You cannot enter, exit. It was a decision, a suggestion from Carlo, but it was implemented by the Vietnamese staff. They decided to lock themselves in the hospital. So the hospital was physically isolated in Hanoi. We just put like which was wall around the hospital. Nobody can enter, nobody can exit. Because we did not know, it was quite frightening, it went so fast. We didn't know what it was, no idea about coronavirus for us. It was a new virus linked to influenza, a new strain. super contagious, super dangerous. So we try to isolate. And I remember telling my friends in Hanoi, if he's going outside the hospital, you run away from Hanoi as far as you could, and you think after. So what they did in Wuhan, they did late, but they locked the hospital. The key, and it's very difficult to implement if you're not it's not self-decided by the staff. Our staff were living in the hospital with our colleagues, because all the patients were medical staff. There were no patients who were not medical staff. So it was the treating medical staff, the sick medical staff, and the non-treating medical staff were doing the food and etc., the logistic from the hospital. So the strict containment is what we have to be working. We're working with WHO and MHS in Myanmar. If it's come to Burma, being strict containment, isolation, blocked. So in Myanmar, we did the same. We locked the hospital, shut down the clinics, stopped the airlines, stopped any blocked, isolated. And we did, it's in the image of ring. So first ring, second ring, third ring. So nobody can cross over. It's extreme. It's not possible to do in Europe because you will not force to have the nurses and doctors or residents or young students to be locked in hospital against their will. In Vietnam, they decided to do it by themselves on the suggestion of Karl Rubani. So it was quite spectacular. It went so well. 10 days, no more transmission. Hanoi and Vietnam was stopped. After, international travel was banned, so it went as a ring outside Hanoi. The global had started, and many hospitals we have the debriefing after in Kuala Lumpur, a couple of months after. What we did in Hanoi, many hospitals advanced in Hong Kong or Canada, which was the worst, never implemented any. They keep moving patients, so they go to CT scan, go for this. No, first we don't move the patient, so the patient will move and were locked in their ward, in their room. The staff were locked, so we just did this different lock. And we stop cross-contamination, which has happened in Hong Kong and has happened where many people have been contaminated going to the CT scan, especially going to the CT scan for procedure. Over to you.
Concerning the testing of SARS-CoV-1, because it was such a new virus at that time, how were they tested? Was it only via symptoms they were diagnosed, or how was the diagnostic procedure?
It's a very good question. We had a cohort. So we have the index patients, and we have a cohort of staff getting sick. And they all follow the same pattern. So first symptoms. Medicine start by a complaint. What do you have? High fever, headache, blood check, lymphopenia, chest x-ray. Not at the first day, day 3, day 4, they start to have the patchy opacities. They all follow the same pattern. So what's the clinical diagnostic? Because coronavirus as pathogenic for human was not known. We have no idea what it is. So we run PCR, mycoplasma, everything, Legionella test. We did all the differential diagnosis on the atypical chest infection, everything. So Legionella came negative, PCR, influenza became positive because there was a co-infection for some patients in Hanoi. So clinical background, basic labs, like we're doing today, yesterday, I have a COVID patient. We don't have PCR antigen testing. You see a patient with chest infection, chest pain, lymphopenia, 100% COVID. And it was COVID positive, tested yesterday. So clinical, basic lab, fantastic. You see your white blood cell, you see your lymphocyte and neutrophil, and think about differential. Always in a new outbreak to say what could it be. You need to think wide, and to see what could it be. Over to you.
Coming back to now the coronavirus, in Myanmar, there's a time where they didn't have the capacity for PCR tests, or that's how I am informed anyway, but that they did antigen tests. Is that still the case, or how does the testing work here?
It's a very good question. So when we get the first patient in late March, we have no PCR. So I need to sample. So WHO was sending the sample to Bangkok. So from the clinical picture, from the basic lab, we need to send by the sample to the reference lab in Bangkok to get the PCR result. It took 1 week. So patients were isolated. The antigen tests start lately. We get it at the first antigen test. I don't know worldwide, but Burma we start to have the first test in late September from Korea. But you know, the antigen tests have a short window and a poor sensitivity, and the positive predictive value is very low if you have no symptoms. So it was start to be used and it's used massively now in Burma, but it's used now today as a first line. It's negative PCR with the second line. It was used parallel, but it will not be a substitute because the test we have is not the Abbott test. It's still Abbott test. You have 5 days. Is 90–85%. I don't know your data, but from your data from Austria. So start with PCR sent to Thailand. Develop the first PCR platform at the National Health Laboratory in Yangon, and the output was limited, was 1,200 tests per day. And we're struggling. The real-time PCR or the point-of-care PCR is, but you know, is 40 minutes per test. Is you can do 50–40 tests a day. And we're using also gene expert machine we use for TB. We have 90 machines in Burma, but it's a very slow output, not suitable for outbreak. So it's now like every countries, like developing countries, they cannot afford to have a massive Roche or Abbott massive PCR machine. You need to combine, like you have some antigen-based PCR, high volume PCR, real-time PCR, point-of-care PCR, and you need to combine. For some countries, we don't do in Myanmar, they do for seroprevalence, but in Indonesia they're using antibodies also to correlate with PCR and antigen to see who they are missing. So today we're still struggling. So in private will be incorporated next Monday for antigen testing, not PCR testing. So antigen testing for some hospital, PCR testing in one lab, and they have developed a new algorithm to see. So everybody is trying to find the best approach. It's the same in Europe, same in your country. PCR is not 100% positive. You need to repeat your PCR. You have any concern with PCR, and Italian people have very shown. If you can see the fabulous studies of Italy, you need to do a bronchoscopy to do your LBA, but your PCR will be positive on LBA. If you have a high clinical suspicion of COVID, you need to do, and PCR is negative, CT scan positive, you will do LBA, and PCR NBA, it would be positive. Over to you.
Now coming to the hospital situation in Myanmar. If you look at the hospital situation here in Austria, a lot of the beds are occupied with COVID patients due to the increasing number of cases. How is the situation in the hospitals in Myanmar, and how is the occupancy rate there?
Well, I will tell you a story. Yesterday morning, I got this French patient called chest pain, high fever, coughing. They come to the clinic for the chest X-ray, and we have a fever clinic, so we see people with full PPE. Even we cannot test, and after we decide, we don't refer to public hospital. And the guy lymphopenia. Well, unfortunately, I would say when you get some experience, you see the patient, you know what is like dengue. You see, okay, this one is most likely. We send him, refer him to the public hospital or the Yangon General Hospital. I don't know if you've been to Yangon General Hospital when you were in Myanmar, and he has been isolated in a ward, waiting to be transferred to privileged ward for expatriate, and during the night, 2 or 3 people died in a ward. All ICUs are full, all quarantine centers are full, 100% full. So our situation today is not dramatic. So we're still in public hospital, have some beds, not suitable for foreigners because we're in a ward and no people, not enough medical staff, not medical nurses, not enough doctors. So the poor French patient just arrived in Myanmar, was in a public hospital built by the British in the 90s with, and people were dying in front of him. I have to deal with this issue all the day and try to still find a bed for him to move to a better quarantine place. So situation in Myanmar, fully occupied. These are our concern today. That's why we need to open private hospital, because Burma cannot cope, public system can't cope anymore with quarantine centers. So we have different graduation. You have the anosmia centers for anosmia, because most people don't have smell, no symptoms, so we just downgraded medical facilities, intermediate medical facilities like stadium, and you have the hospital medical facilities caring people, I would say, with low oxygen requiring people, people who are high risk to decompensate with diabetes, age, etc. Today we are, it's not on the publication, it's not on the slide I've shown you. Fabio might tell you it's mostly fine, it's not fine. We are facing a very big challenge today in Burma, and for the expat community, it was a wake-up call, because people pretty relaxed, that they were thinking that we have a beautiful plateau for the last 2 months, but the plateau is not a real plateau. We are missing many cases, and for the expatriate, we start to forget about PP, social distancing, and now for the French community was a hard story today, and people were more cautious. So we are not over from the problem, and we're still struggling a lot, massively, with the disease. In Myanmar, 100% of people entering ICU, intubated, ventilated, who are going to be intubated, ventilated, will die. I don't know your ratio in Australia. In UK today, in US, is 50%. In Burma, if you start to be intubated, ventilated, finished, game over. So it's terrible for patients, terrible for the public, terrible for the doctors and nurses, because they start to be completely demotivated, drained. And we've seen in Italy, we've seen in your country, in Germany, in France, the medical staff cannot cope with the burden. It's too much for them, and they don't believe anymore. So we're facing now loss of discouragement among the public staff, or hopefully the private sector will reduce the burden of the public sector, but it's a huge burden on the medical people, especially nurses, frontline medical students like yourself, and doctors. So still extremely difficult for us. Over to you.
How does the ventilation look like in Myanmar? Here in Austria, we have a good infrastructure, so we have a lot of ventilators and are able to intubate quite a few patients. How does it look like in Myanmar?
Well, this is a very interesting question. We have more ventilators than people that can use ventilators. So we have enough ventilators. We have a discrepant type of ventilators. So one of the struggle a different struggle, we go back, we don't have enough nurses and doctors trained to use ventilators. This is the first things. So we have enough, the numbers of ventilators are enough, but the type are discrepant. So you have old model, new model, you have, and when the supply chain came, people want to donation, they give different type. And you know, ventilators, different settings. You use a draggers, they have their own software. You use different types. So every hospital has different type of ventilators. The main issue, we don't have enough doctors and nurses trained, experience for ARDS ventilation. And myself being involved, I'm not here involved in ventilation of ARDS, but in Hanoi I did with my colleague. I'm not an intensivist, but my colleague intensivist, and it's extremely difficult. Now we know that you move people prone. It's easy to say. You need a complete team to move people. When you move people to get this load, you need to intubate. You need all the pitfalls of the ventilators. You ventilate people with high pressures. The alarms always go on. It's not done for junior intensivists. It's done for senior intensivists. In Burma, we don't have enough senior intensivists per hospital. So what happened? You have junior intensivists caring about patients. First alarm, well, finish, game over, you get tension pneumothorax, like many people die. You have cardiac failure on the high, so you get a classic cardiac failure and cardiac arrest on the high resistance. So this was the fact. So there was an interval period where we were proposing with WHO and some UN agencies to send people from Italy, from different countries. Italy gets some people from Cuba to help them. They need some help. They refuse external support. It's a mistake. 2 months ago, Italy was wishing to send the top intensivists and chest physicians to train people. on hand. You don't train people on ventilators on Zoom. When the machine is beeping, the SAT is going down, you have a tension automatic, you don't learn on Zoom. You need on hand. You have done 2, 10, 20, 100 patients. You know how to do it. So all experience grown we had in early 2020 in Europe is needed now in Burma to train young intensivists and ICU nurses to cope with a patient fighting on ventilator. It's pretty, I don't know if you went to ICU as a medical student, it's pretty scary if you have inexperienced nurses and doctors and a ventilator, a patient crashing on the ventilator. It's a horrible scenario. So this is what has not been discussed today on the WHO MOHS conference. I think I need to discuss with Dr. Fabio next week. It's the thing we've been pushing very hard with Dr. Fabio and WHO. I'm part of the panel doctor for the clinical response of Myanmar for WHO and MOHS. So we're pushing very hard, but still we're reluctant to get foreign people to. So once you train your people, it's on hand. You know how to manage one type of ventilator on one type of IRDS. You know all the pitfall and your algorithm. You know how to put your chest tube, the compression needle. You know how to adjust the settings. You know what to do. If you know how to reintubate quickly your patients. It's lots of things that Burma was still not yet ready. Over to you.
So just for the audience to clarify what MOHS means, it's the Ministry of Health and Sport. So that's the ministry in Myanmar, which just for as a clarification. One of the last questions is concerning the second wave. So one of the questions that came in was, how did Myanmar learn from the first wave, and how did they respond to the second wave, and what do you think will happen in the third wave, or if there will actually be a third wave in Myanmar?
Well, it's a very good question. This has been discussed this afternoon at the cluster meeting with WHO and MOHS. Well, first is testing. We need to increase dramatically the capacity for testing for Myanmar. If you have a disease, first thing, whatever it is, HIV, malaria, or coronavirus, need to make the real diagnostic. When the real diagnostic, when you can test, you can make faster. You know that you have a very short period where you can do effectively contact tracing 2 to 3 days. So test fast, do your contact tracing fast. So that's what we have learned from the second wave. We failed because in fact, we were so happy to have controlled so well the first wave that we will forget that it will be reintroduced by the borders. And we have this massive local transmission. And the numbers of cases was over the capacity of testing. So capacity of testing, Korea has been successful, Taiwan, and I don't know your policy in your country, but the same in France. Test as maximum. Test, isolate, contact tracing, and when people become symptomatic, go to the adequate centers. So there were lots of progress of developing quarantine centers and anosmia centers and upgrading the hospital, HDU and ICU, still with my reserve on ICU, and intubated ventilated patient is super complex. Still Burma have to work on it. So second wave is where we are, more testing capacities, better coordination between the regions, because Rakhine was disconnected from Yangon, and combining antigen and PCR, immediately contact tracing, and so far, the law in Burma, you have contact, you go to quarantine center, because Burmese families are nuclear, people are living together in a small space. And the third wave, well, it's been today discussed with WHO and MOHS. We were expecting a third wave. So it's a loss of, from myself, as personal view, and some friends who are working in Yangon General Hospital, the third wave is just a second wave in continuity. Because so far we have not seen, we're just a small decline, but that's artificial. I think the third wave in Burma might be just a second wave expanded. because we cannot test so much. We don't know the real extent of the outbreak nationwide. And Burma is poor, lots of remote places, lots of conflict area, many places we cannot test. So we can test mostly Mandalay, Yangon, Naypyidaw is easy, and other cities like Molomien and Sittwe and Rakhine. Other places you have no testing capacities. So the third wave is probably just a second wave with better data. So we see called a third wave because numbers will increase again. This is not a real third wave, it just be a continuum from the second wave. Let's see what's going in January. I will be cautious. For us, this week we reinforce about COVID is not under control in Burma. Situation is not a disaster, it's not under control. Just to be super cautious. For us, we hope the vaccine introduced in April will help. First, to protect healthcare workers. The ratio population to healthcare workers in Myanmar is half you have in Austria. So huge shortage of doctors and nurses. So we need to protect the healthcare workers. And let's see what's going on in the first quarter of 2020, knowing that we're entering the dry and very hot season. So it will be a good way to control the disease. But so far, prediction, you know, I'm not a fortune teller, and all fortune tellers are pretty wrong on COVID, especially the expert fortune tellers. So as was saying before, let's be humble, let's be cautious, let's wait and see, and let's do the best for the time being. The best as we can in our city.
Now coming to the last question that was asked, it was in some of the last presentations that we had, the last talks that we had, it was mentioned that in Australia this year, there were hardly any influenza cases. Is that the case as well in Myanmar, or have you not noticed that?
Well, it's a very good observation. We have no flu this year also. So it's very interesting, and normally the monsoon we have. Let me explain the weather in South Hemisphere for people not familiar. The winter is for us. We are living in North Hemisphere, but what we call winter in a tropical country North Hemisphere is a monsoon. Monsoon starts in June, May-June start and land in October. This is a cold and rainy season, and a season for influenza and for dengue fever, etc. We have a small peak of influenza now during our winter time, which is they call their summertime because it's hot and dry, but the temperature are going cooler. So December, January was second peak. The main peak for influenza is the monsoon period. That means the summertime for us that they call winter time, but still North Hemisphere. So what happens this year? We were all scared. In Fabio, WHO, all of colleagues will say, my God, we're going to get COVID, influenza, dengue, we will get everything this year. And we had dengue, of course, because dengue is not linked to it's mosquito-borne and it's not linked. But people have been staying mostly indoors. For foreigners, we've seen very few dengue cases compared to last year, because people were practicing social distancing and wearing masks. Almost 0 cases of influenza this year, which is the first time in 15 years in Burma I do not see influenza. Very strange observation. I'm very happy they've seen the same in Australia. That's been, you know that influenza is 3 times less contagious than coronavirus. You wear a mask, you wash your hands, you wear a face shield, social distancing. Well, it's a way to control flu. It's what has been done by during the Spanish flu. So it helped to control coronavirus. We have seen little flu. We're so happy. Let's see what you will see in your winter in Europe, in Austria and France, Europe. I would be very curious to see your data from Europe. But for sure, wearing a mask, social distancing is a preventive for flu and coronavirus.
Well, this was the end of our questions. Thank you very much, Dr. Olivier, for taking your time and answering some of the questions and presenting on this very interesting and very informative topic. For me especially, I thought it was very, very interesting to hear the similarities and differences between SARS-CoV-1 and SARS-CoV-2, as right now we've only heard more about the whole SARS-CoV-2, so COVID information. Thank you very much for taking the time. For all our listeners and viewers out there, I would just like to thank you for watching, for tuning in. I hope you enjoyed this very interesting talk. I would like to inform you as well that we have another talk coming up this evening at 6 o'clock, this time in German, with Dr. Juliane Burkhardt, where she will be talking about the psychological stress during the lockdown. So looking at that, the psychological perspective of this whole pandemic. And then for everyone who's still interested, and I know it's very close to Christmas, but on Monday, the 21st of December at 3:30, we have Dr. Fabio Mesquite, a colleague of Dr. Olivier.
He's a great guy, great colleague. Fabulous.
He's a Brazilian doctor, a Brazilian epidemiologist, who also works for the WHO. And so he'll be talking about his own personal experiences with this pandemic and what he has noticed in an epidemiological perspective. At 6 o'clock then on Monday, we have Dr. Olivier Scheibenbogen. He is from the Anton Proksch Institute in Vienna, and he will talks about the topic of, is the corona crisis a psychological pandemic? So please tune in if you want to have more information about the next couple of talks. Go onto our website, which will be then shown at the end of this presentation, or check out Instagram or our Facebook channel for more information. We hope we gave you some interesting information. I hope you enjoyed the conversation or this presentation from Dr. Olivier Cattin, and I hope we will see you again next week. Till that time, I wish everyone a nice 4th Advent, which is coming up on Sunday, and yeah, see you next week. Thank you very much.
Thank you, Tim. Thank you to all the colleagues from Australia. Bye-bye.